Hi, this is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure of welcoming Dr. Sarah Ferguson, who is at the Princess Margaret Cancer Centre in University Health Network in Toronto, Ontario, Canada. The reason for this podcast is going to be a discussion on the recent publication in the Journal of Clinical Oncology titled Sexual Health and Quality of Life in Patients with Low-Risk Early-Stage Cervical Cancer, Results from GCIG, CCTG, and the SHAPE trial comparing simple versus radical hysterectomy. Sarah, thank you so much for joining us in the podcast. Thank you for accepting our invitation. And once again, congratulations to you and the co-authors for this really important publication.
Thank you, Pedro. It's a real honor to be here and giving us the opportunity to talk about this work, which we're really proud of.
Excellent. Yes, so we're really excited. Lots of questions turned in also from our fellows in the International Journal. So I wanted to start by discussing the relevance of sexual health as it pertains to radical hysterectomy and what did the literature show us prior to this study?
Yeah, thank you for that. So I think all of us who treat GYN oncology and those who are interested in patient-reported outcomes have known that cervical cancer patients seem to fall out very heavily on being distressed or finding their sexual health significantly changed in an adverse way after treatment. And lots of publications on that, more, retrospective, really mixed populations. So a lot of advanced cancer with definitive chemo-RT, some with surgery, and there had been like a few prospective studies looking at the effects of surgery alone, specifically radical hysterectomy, but they were compared with non-surgical arms. So we really didn't have anything that showed what's the impact of our surgery. And quite frankly, I think when we started this, so this is Marie Plant's baby, but our team had Lori Brotto, who's a sexual health expert, and I was very interested in sexual health research. I don't think as a surgeon, and this is probably a bias of surgeons in general, that I thought there would be a significant difference. I think most of us have kind of felt that it's surgery itself, it's transient, it gets better. And then most of the toxicity is related to our radiation colleagues and what they do. So, I mean, maybe it was a bit naive. So I think there was little data on really what was the impact of what we do and the radicality of what we do for cervical
Great.
cancer.
Thank you so much for obviously setting it up and giving us that background. Very, very pertinent and important. And I wanted to just then follow up with regards to if you can just give us a brief overview. I don't think there's anyone in G1 oncology who is not aware of the results of the SHAPE trial.
Yeah.
But if you could just give us a brief overview of the primary objective and what were the findings.
Yeah, so the primary objective was so it's a randomized controlled trial looking at non-inferiority of oncologic outcomes, and the primary outcome was 3-year pelvic recurrence rate. And so this was early stage low risk, so very select patients, small tumors, less than 2 centimeters. They required an MRI. To ensure that they didn't have more than 50% invasion. So really a low-risk group. And, the hypothesis was that oncologic outcomes would be non-inferior for less radical surgery with a simple hysterectomy. And then to look at secondary outcomes, urologic outcomes, and sexual health and quality of life. So that was, and the primary outcome, as we all know, is that the oncologic outcomes were non-inferior. And then there were more adverse events with regards to urologic, which I think plays into the sexual health outcomes as kind of a story of the impact of the surgery.
Great. So now let's get into some of the details of this study. Tell us about the methodology as it pertains to the quality of life component of the SHAPE trial, and why did you choose the tools that were incorporated in this study?
Yeah, so we used fairly well recognized and validated tools for overall quality of life. So the EORTC, QoL 30. And then for sexual health, we used a little bit of overlapping tools. So first, the Female Sexual Functioning Index, which was first developed not in the cancer population, but looks at functioning and has been validated in different cancer populations and even has been shown to show differences between cancer populations treated with different modalities, so radiation and surgery. We also looked at distress because if you're not bothered by having a change in your sexual functioning, maybe it's not important to you. So I think distress is part of the whole sexual health picture. And then we use the ORTC QLQ CX24 because it talks about specific cervical cancer treatment symptoms and perhaps cancer-specific symptoms as well as sexual health. So they are complementary, I think, the CX24 and the FSFI for some of the functioning, but each have they're not completely overlapping, so it adds a little bit more.
Great.
And then what we did was, so those are the questionnaires we used. We did at baseline and then 3, 6, 12, 24, and 36 months post-treatment between the groups. And these were compared at each of those time points.
Yeah, and it's always
sorry.
Yeah, I'm sorry, go ahead. No, I was going to mention that it's always really important to have, as you did, this series of time points, particularly for quality of life, because obviously some of the other previous studies in gynecologic oncology, when they looked at quality of life, oftentimes it was just a one-time or a two-time frame.
Yeah, and I think when we start talking about the results, I think that's important because though there's differences, I think there's also some encouraging things about what happens over time. One of the things that was maybe we would do differently in the future is to participate in the study, you had to agree to complete the quality of life component, but we did add a second consent form for sexual health. And it's interesting because I think, things changed. And I think we've normalized that sexual and vaginal health is all part of toxicity of cancer treatment for gynecologic cancer. And that I don't know if we would have done that. But maybe selected people who were very motivated to participate in that part of the study, and that's reflected in our pretty high completion rate of the questionnaires over time.
Yeah, and that's always impressive, obviously, when there's a high completion rate, particularly over time, over multiple segments of evaluation, and overall in the population as a whole. So congratulations for that. So now actually, what were the findings pertaining to quality of life and shape specifically? And then we'll get on to some of the discussions of those findings.
Okay. So you think I'd have it all memorized in my head, but I did review it. I have them, but I do. So, I think which isn't surprising, these were young patients with low cancer burden. So their overall quality of life, when you look at not the sexual health component or the cervical cancer specific component, but the QLQ 30, they did not have very low scores. They had high scores. They were similar at baseline. They didn't really dip that much over time. There were a few time points that stood out, like at 3 years overall. Global health was a little bit less for the radical hysterectomy group, and physical activity was a little bit less, but nothing that was really striking. So basically a healthy young population with low symptom burden. And then when we look at the sexual health component, I think that there were some important things that didn't change over time. And, specifically, when we look at FSFI, it does look at orgasm, which is important. So that component and sexual satisfaction weren't really that different. But what was consistent between the CX24 and the FSFI is that changes in kind of vaginal health or sexual vaginal functioning. So, lubrication as measured by the FSFI, and they're different measures and they ask different things. So they're a little bit nuanced, but it was worse for 12 months, up to 12 months, and then seemed to go back to close to baseline on the FSFI. Pain was worse, and that domain, asks about entry and deep pain. And then when you looked at the CX24, their domain it's a multi-item measure on sexual vaginal health, which asks a little bit more specific to cervical cancer. That those changes were up to 2 years, and the differences were striking. And this was the area, there were differences in other areas we can talk about, but this was striking. And when you talk about minimally important difference, it certainly met that initially, and it stayed even, and people use it different. Some say 5, some say 10, but it stayed for a long time. It was statistically different up to 2 years, but then seemed to improve and go almost back to baseline. So I think it gives some, and it aligns a little bit with the bladder dysfunction that was found in the study, that urinary incontinence was bad short term, but even worsened over time. And same with urinary retention, was significantly worse in radical hysterectomy short term and did not improve over time. So it kind of gives the idea that there's something related to the surgery itself causing these changes. There were some transient changes in, arousal and desire that, were kind of a blip. And you could say, I think anyone going over major surgery, that could happen. So I'm not sure how to pull that out, but lubrication, pain, sexual vaginal health, and sexual activity decreased for sure in the radical hysterectomy more than in the simple hysterectomy for even up to 2 years. So I think that those are the main take-home messages with regards to sexual functioning.
Okay, so now let's get a little bit into some of those details. But I first wanted to ask you, and we have briefly alluded to this before, what was the compliance overall? Can you share that with our audience?
Yeah, so approximately, 70% or 70 something, low 70% of people did the overall quality of life. And over time, by 36 months, it was about, I think, 50 something percent. And in the sexual health component, there was less patients in that, but still a large number. It was about 80 something, 85% did the baseline. And then by 36 months, it was about 60 to 65%. And it kind of slowly dipped down, but at many time points, we had over 70, 75. So, and I think for a longitudinal study in this patient population, I think that gave us some robust data.
Yeah, absolutely. And generally is consistent with what we've seen in other studies in terms of compliance. Now, this question actually came from multiple fellows, so not attributed to one specifically. So their first question is, do you think patients understand that a radical hysterectomy could impact their sexual function more than a simple hysterectomy due to the amount of tissue that is removed, presumably vaginal tissue, parametrial tissue?
Yeah.
And they follow it up with, I wonder if there's an inherent bias to
Yeah.
them knowing what procedure they're getting and then worrying about actually having sexual function.
Yeah, I thought that was a great question. And I think, this study, obviously people are not blinded to what they're having. And so, I think that certainly it could affect potentially. It would surprise me that it would be so persistent over time. That where people got confidence that if they didn't have pain or they didn't have changes in lubrication, that they'd feel more confident and it wouldn't still score so abnormally. But I think it's potentially possible. The only other thing I think about is that when I was recruiting to this study or introducing this study, I didn't even think about the sexual health component or the impact, like when I was introducing it, because it's, as you know, doing surgical studies, it's hard to ask people to do something that's different than the standard of care. What would you do if you're off study? And I was really focused on the oncologic outcomes, and that we thought it was going to be fine. So I don't know if many healthcare providers probably focused on that because it was a hard study to recruit to, and most of us focused on oncologic. But if they did any reading or Googling or whatever, potentially it could have biased.
Yeah.
You know,
Yeah,
that's a
absolutely.
limitation of a non-blinded study, I guess.
Completely agree. Yeah. This next question is from Manel Montesinos Albert in La Fe in Valencia. And he asked, how did the study differentiate symptoms of dryness and lubrication in patients who underwent oophorectomy to determine whether these were due to menopausal changes or a direct adverse effect of the surgical procedure?
Yeah, that's important. And, I know you'll probably ask me what we would have done differently. But when you finish the study, you realize there's so many things you would have done differently. And one of them would be to collect the data on surgically induced menopause. We indirectly have some information to show that not that many patients had significant menopausal symptoms. So vasomotor symptoms were a little bit different, but not strikingly a problem for these patients. And usually for surgical induced menopause, that would be a really striking feature even before vaginal changes, because that takes time to have changes with vaginal dryness. And our patient population, 80% of them were less than 50. And most of us, and usually it's for HPV independent cervical cancers, would we recommend removal of the ovaries in a young patient population? And if for some reason we did, I think most of us would give estrogen back. So things that we would have done differently is collect that data on who we put into menopause and who was getting vaginal, systemic, or local estrogen. Which we did not collect
Yeah.
because it's a
Yeah,
hard thing to do.
leave it to our fellows to ask the challenging questions. So,
Yes, I know it's a good question. And, in our discussion, we tried to address it. I do think that the vasomotor burden for this patient population, either people replaced it, but very few had oophorectomy. It wasn't statistically different, though there were more oophorectomies in the RADHIS group, but it didn't meet statistical difference. It's hard to know. I think it takes time for those changes. It's with regards to vaginal dryness as opposed to the vasomotor symptom.
yes, that's absolutely. This next question comes from Christian Braun in Lucerne Hospital. Are there any data available on the type of radical hysterectomy performed in the study, specifically regarding the frequency of nerve-sparing techniques? Additionally, were any sub-analyses conducted to compare sexual dysfunction among nerve-sparing radical hysterectomy versus non-nerve-sparing radical hysterectomy versus simple hysterectomy?
Yeah, so I don't believe people perform nerve sparing. It was, we had a surgical protocol and we did not include nerve sparing. I know that there are some institutions, especially in Japan and elsewhere, where this is routine, and I don't think it's been incorporated internationally. So I would be comfortable with saying I think that there would be very few that intentionally had nerve sparing surgery, other than the simple hysterectomy group.
Yeah.
But I think it's important that this is probably the next frontier of minimizing radicality and impact on patients, because there are still patients we need to do radical hysterectomies on who have larger tumors, who have histologies that we do not think are HPV dependent and we're worried about. And so, as you know, adopting something without evidence, we've been wrong in the past. And though this would be it would take 20 years to recruit to the study with the smaller indication for radical hysterectomy, but ideally that there's some data standardization of the technique. I mean, I'm very interested in it. I don't do that. And standardization of the technique, and then some prospective evaluation to ensure oncologic outcomes for the larger tumors are maintained. I think there's good retrospective data on that, but I think prospective. Good questions.
Now, this one comes from Clara Santia here, actually, at Methodist in Houston. Although sex-related distress was reported in both groups as being in the non-clinical range at baseline, what do you think could explain the significantly higher proportion of patients in the radical hysterectomy group who were in the clinical range of distress at 3 months compared to simple hysterectomy?
And it's a good, I would have thought they would, I'm actually surprised at how the distress it wasn't more persistent if they were having significant sexual vaginal health, sexual vaginal changes. And I think it lends to the idea that sexual health is really complex. It's a biopsychosocial model. There's lots of things that protect against it. Your state before an event, whether you're partnered or not, people's ability to adapt to change. So it's hard to know. I do think that patients in the radical surgery arm had a lot more going on. They had a lot more urinary retention, incontinence, pain. If they were starting sexual activity at around this time, maybe it was more distressful because 3 months post rad hyst is still pretty early, and there would be changes in the pelvis that may cause acute pain. But it did resolve, though, and become equivalent with the simple hysterectomy group, though you can see that they didn't completely revert to their baseline with the sexual distress, which is kind of just highlights the complexity of sexual health. Yeah. Beyond a cancer diagnosis. Then you add on a cancer diagnosis that is related to our, reproductive organs and has the stigma of being sexually related to HPV. There's a lot of complexity.
Yeah. So as a follow-up to that, Julia Gellison, she's asking, do you think there are any characteristics of the different questionnaires that account for differences in patterns seen between their outcomes?
Yeah. Yeah. I thought this was a really great question as well. And it made me think a little bit about these questionnaires. So the obvious things is they ask, one says over the last month, the CX24 is like over the last week. Does that create changes? The FSFI has a lot of items for each domain. So when they ask about lubrication, they ask 4 different ways. So not, intensity, how often, but like how confident you are, like sustain. Like, so it's a lot more nuanced to get that domain, where the CX24, probably because it's part of a whole big one, is a little bit more direct. So sexual vaginal is just really pain. Does the vagina feel short, tight, and is there dryness? There's no so I do think that creates a little differences, but I think the overall message is it's not like in one it was, they were having differences in orgasm, and one it was pain. They are different scales with overlapping domains, but they're all in the same direction. So it gives it a lot more validity and I don't know why in, some of the things like body image, they stay separated with rad hyst being worse. Like I try to think about that. That one kind of stands out to me, but all the other ones are short term and get better. And I think what's also important is that most of these do get better over time. And we can talk about things that maybe in the future we can make this not be as significant as it is, other than doing a simple hysterectomy.
Yeah, and I think you bring up an excellent point with regards to the questionnaires themselves, in regards to obviously how well aligned they are with each other, how the questions are posed, and then also obviously how patients interpret that question as well. So very, very interesting points. Now let's go on to Clara Santia again. She's asking, what are your thoughts regarding the fact that there were no group differences in lymphedema and peripheral neuropathy?
Yeah, I think that's related to the fact that all of these patients had they're randomized, so all the characteristics that we don't measure that maybe put them at risk for lymphedema were hopefully balanced, and everyone got a full lymph node dissection. That was part of it. They didn't have sentinel node by themselves. So I think it just shows that these were pretty well balanced, randomized study. And, there is a certain percentage of lymphedema with a full pelvic lymph node dissection, but there's nothing about radical hysterectomy that influences that. It's more about the nodal dissection. With I think that the EORTC, the cervical cancer module is covering all different types of cervical cancer. So they talk about neuropathy, but very small percentage of patients got adjuvant radiation with cisplatin. And I think that would be the biggest thing causing neuropathy in this young patient population. It just wasn't very significant.
Yeah.
Which is good.
This next question comes from Stephanie Gill at the University of Toronto, and I think I know what the answer to this is going to be, but obviously I think it's an important point and oftentimes a challenging metric to measure. But she's asking, did you gather any information in the SHAPE trial about vaginal length post-procedure? I wonder if there would be a correlation between vaginal length and worse scores for sexual function and distress.
Yeah, we didn't gather that information because it just, these studies are hard to do, and less data we collect sometimes is better. But I think it would be interesting. I always think that the patient's perception of the problem is more important. I think in a non-radiated vagina, if there's estrogen around, losing a centimeter or two, depending on the tumor, I guess, most people can accommodate over time, and the length isn't as big as issue as compared to postmenopausal women or people who get radiation of some sort. Then it becomes, a real problem. But it would be interesting. I mean, we just published a study this recently looking at our definitive QoRT group and looking at provider rating of vaginal changes, toxicity, so dryness and change compared to the patient-reported outcome, and they did not correlate. And I know vaginal length is a little bit less subjective than a physician scoring on atrophy and loss of length, but it was all it was a combination of length and dryness, elasticity, and then the patient, and it didn't correlate. We underestimated compared to what. So I think it would have been interesting more as just to see if there's a correlation, but I think that's why we have to focus on patient-reported outcomes.
Yeah, very
Because
important.
maybe it isn't bothersome,
to,
even if it's
reading
shortened, or maybe it is.
Yeah, no, I'm looking forward to reading that, and it doesn't surprise me that that there was no correlation or lack
Yeah,
of.
it didn't correlate at all.
So then now this question comes from Matteo Marchetti in the University of Padua. Which symptoms do you believe are most strongly associated with vaginal shortening, and which symptoms with neurogenic damage? For the latter, how do you explain the subsequent improvement in these symptoms over time?
So I think it overlaps. I think so the inferior hypogastric nerves, run through the parametra, the uterus sacrals, but they also are in the top part of the vagina anteriorly. So I think all of it has potential to disrupt. My feeling is that if someone, like I said before, if someone has estrogen and they haven't been radiated, the length they can accommodate with, not always, but most can. And I think that it's the disruption of this nerve plexus, because it aligns also with the changes that we saw in the bladder, which were not insignificant in the study, in the radical hysterectomy group. And we know that it innervates both of these structures. So I think that it shows that lubrication is, vaginal atrophy from lack of estrogen is one thing, but then its ability to have lubrication during sexual activity and during arousal is a different thing as well. And I think that's related, more related to the inferior hypogastric. So I think it's overlapping. I think it's combination. But I think that we don't take all the nerves, so there is some recovery. Also, we don't know what people have done. I mean, I think we're all, as physicians, we talk about vaginal health. You know, you do the three things: lubricant, moisturizers, and estrogen. So hopefully people, and now physiotherapy, pelvic floor physiotherapy. So maybe there was intervention by themselves with, and so maybe that's why it improved, and also nerves, some of the nerves recovering that weren't completely removed. So
Excellent. So, Sarah, obviously, a prospective randomized trial, prospectively collected data, high compliance in this patient population. What do you see as the weaknesses of this study?
yeah. So I think it would have been nice to have everyone participate and not have a separate consent that, you know, and I think we would have done it differently. Maybe we would have more people participate. Maybe not. Maybe we selected the most motivated people to participate, and that's why we have high compliance, as I said before. I think the fact that we didn't collect menopausal status or treatment-induced menopausal status and use of HRT locally or systemically are probably the biggest answer, problems, because we can't 100% answer the contribution with the vaginal change, though I would argue it takes time for those vaginal changes, but that would have been good to know. And also to know if it helped with intervention. I mean, maybe people got better because we did give local vaginal estrogen or whatnot for patients who were suffering. So that would have been better to do that. It would have been harder. It's not as easy. I've done it in many studies trying to collect that information. It's hard. So to make,
So, Sarah, now as a last question, there's a question from several fellows. Is there anything that we can do to avoid adverse impact on sexual health in those patients who still need a radical hysterectomy?
yeah, I think so. So I think, first of all, I think counsel that this is a toxicity. I don't think any of us really counsel, or I didn't. Maybe you did, I didn't. Toxicity, that it's a potential. And I think we have to be proactive. So keep the ovaries in if it's reasonable. Um, even if you don't think someone should have systemic estrogen hormone replacement, give local estrogen if they are already in the menopause or are postmenopausal. I always tell the fellows vaginal health, so lubrication during intercourse, moisturizer just to moisturize like your skin, and then estrogen if needed, and often is the best thing. And then thinking about pelvic floor physio, and probably that would have an impact on their bladder function as well, because especially with pain, it can be related to scarring in the pelvis, adhesions in the levators and all and whatnot. So I think that pelvic floor physio now is really common and accessible as opposed to 10 years ago where it was hard to find them. And so I really encourage patients to explore that. It's a bit of a commitment and it costs money, but it's something to talk to your patients about.
Well, Sarah, thank you so much. It's been a lot of fun, and I've
Yeah.
obviously, I've learned a lot. Thank you for accepting our invitation to discuss this paper. And once again, congratulations, not only actually for this manuscript and contribution, but for all that you have continued to contribute to gynecologic oncology.
Oh, well, that's kind of you. It's so fun, a bit nervous, but it's great. And I'm glad to you know, get this information out there to our audience.
Thank you.
Take care, Pedro. Thanks, everyone.